Good evening, everyone, and welcome to this very special ESGE ESGENA webinar on COVID-19 and endoscopy. My name is Gralnek, and I'm the Chief of Gastroenterology and Hepatology at Endoscopy Medical Center in Afula, Israel. I'm also the Secretary General of the ESGE, and it's my honor to be the moderator tonight. I am joined by really an illustrious panel of physicians and nurses who have been on the front lines of the European epicenter of the COVID-19, and we will be introducing them momentarily. I just want to remind everybody in terms of the ESG webinars, this is now the third year that the ESG is offering high quality webinars. These are on a monthly basis. They are completely free. This is a special webinar, but generally our monthly webinars are on the second Wednesday of every month at 1900 hours of Central European time, and I invite everybody in the future to join us for these webinars. Tonight's topic, as I've referred to, is on COVID-19, protecting your patients and endoscopy unit. I'm joined by several panelists, Dr. Cesare Hassan. Welcome, Cesare. Cesare is the treasurer for the ESGE. He is a gastroenterologist in Rome, Italy, and has been on the front lines of the Italian COVID crisis. And he is also the co-author of the ESGE position statement on COVID-19 that is on the ESGE website. And I invite all of you, if you have not seen that, to please log on to the ESGE website and review that position statement. Second, I'm joined by Professor María Pellisé. Maria is a gastroenterologist in Barcelona, Spain, also an area that Maria has been on the front lines with fighting COVID-19 in gastroenterology and endoscopy. She is a member of the ESGE governing board. She is also a member of the governing board of the Spanish Endoscopy Society and is an associate editor of our journal Endoscopy. Welcome, Maria. Thank you for being here this evening. Next, I'd like to introduce Dr. Alanna Ebigbo. Alanna is a gastroenterologist and is also an infectious disease specialist in Augsburg, Germany at the Augsburg Clinic Hospital. And we are very happy, Alanna, that you are here because you bring two perspectives, not just as a gastroenterologist endoscopist, but also as a specialist in infectious disease. So thank you for being here. And last, Ms. Ulrike Beilenhoff. Uli Beilenhoff represents ESGENA. Uli is an endoscopy nurse teacher in Germany. She is located in Ulm, Germany. She is also the current scientific secretary for the ESGENA and is also the current president of the German Endoscopy Nurses Society. So Uli, thank you also for being here tonight. It's great to have you representing ESGENA. So tonight's outline is an introduction, which we've really gone through. We're going to have a couple of presentations from our panelists, and then we really want to open this up to questions to our panelists and to you, our audience, for an open discussion for the remainder of the hour. If you look at your platform for the webinar, you'll see that you have the option of sending questions, which will come through me, and then I can refer these to the panelists and get your questions answered. So please be sure to use that feature of the webinar. Also, I want at the very end, you're going to be emailed an evaluation for this webinar, the ESG. We think this is very important that you complete these evaluations so we can get feedback from you of how the webinar was and how can we improve things in the futures. If your questions have not been answered tonight, you can also email me, the moderator, or any of our panelists for additional answers. This webinar will also be recorded, or is being recorded, and it will be on the ESG website. So I invite you to review that if you'd like, or tell your friends to go there if they were not able to be on the webinar tonight. So enjoy watching and participate. And now I'd like to invite Dr. Cesare Hassan, who will do our first presentation. Cesare.
Thanks, Ian, and welcome you all. The core of this position statement is, please next slide. The core is, of course, the amplification of COVID-19 within the hospital. In Italy and Spain, we estimate that 0.1% is the prevalence of COVID-19. Now, 10% of all COVID-19 cases in our population are healthcare providers. What does it mean? It means that we are at 100-fold increase of risk as compared with the general population. I repeat, 100-fold increase. This is our risk. If this is dramatic, it is even more unacceptable that 1 every 10, in Spain also 1 every 5 at the beginning, of healthcare providers are actually infected. This means that we need to overreact. Ayan, let's assume that we are 1,000 in this webinar, okay? It means that 100, 200 of us are potentially infected. So these numbers are terrible. And the third factor is clusterization. You can be good in preventing the first case of infection in your department. But if you fail, the second, the third, the fourth will come. And the entire department of endoscopy in Italy, and probably also in Spain, I guess, have been completely closed. And this is a disaster. This is what we need to avoid. So this is the core of our position statement. And what Ayan and all the governing board did was to explode it on the two main pillars of a position statement: the safety, that is the risk, and the efficacy. Let's start with the safety. There are 4 or 5 main bullets in our position statement. First, 1 every 2 infections are due to asymptomatic patients. So don't think that it is like with influenza, when patients come with 40 degrees of fever, headache. No, here patient can be virtually completely asymptomatic, because between the start of the infection and the start of the symptom, even 2 weeks may occur. And this is when the patient may be dangerous for us, and we may be dangerous for the patient. Let me say this to you, because this is outstanding. In China, it has been demonstrated that if you scope a COVID-19 patient, you are actually protected. You know why? Because you overprotect yourself. But you don't know if the patient is COVID-19, it's when you underreact and you get infected. The second point that is somewhat dramatic, but also characteristic in this outbreak is the shortage. For the first time, we have shortage of masks, we have shortage of goggles, we have shortage of everything, we have shortage of testing. And this need to rationalize. We cannot do as many procedures as we were doing before. The third point is that all the triage is to diagnose, but all the diagnoses are to isolate. If we don't have infrastructure, if we cannot differentiate between clean area, partially contaminated area, fully contaminated area, if we don't have clear instruction, if we don't have enough protection according to the degree of contamination, all our diagnoses are completely irrelevant. This is why every city now has a COVID-19 center. And the last point may be somewhat less important, but it's not so much. And this is cultural. In Asia, they were very fast in defeating the COVID. Look at Japan, look at South Korea, look even at Hubei. And why? Because they work as a team. For them to use a mask, to have a physical distance, is a sign of trust, it's a sign of friendship. Now, don't get angry with me, Aya, but when you look at the Americans, they are very individualist. They don't like to be covered. They don't like physical distances. So there is also a difference in culture. And this is why in Europe, we have a threefold increased risk of healthcare provider infection as compared with China. But I guess that we need to pay tribute this time to our president, Mario, because he also looked at the other side, that is the side of efficacy of endoscopy in COVID-19 outbreak, because there is a disruption. There is a real disruption of our activity. In northern Italy, the worst outbreak in Europe, Ale Ripicci estimated that between 75 and 90% of procedures have been completely cancelled. Because, of course, we feel that we are the risk for the patient. But what is this burden? All of these diagnoses that we are missing. And there is also a shortage of ICU. So patients with cancer in Italy cannot be operated. Who should we prioritize? And if we postpone, when we should postpone? All of this is in our position statement, because we also need to look at the burden of COVID on endoscopy. And of course, I'm sure that among these 1,000 providers in the audience, 1,000 friends, there are a lot of trainees. What are the implications of COVID for trainees? Of course, most of them have been reshifted in the internal medicine world, but also what about the research? What about the e-learning? How can we compensate for this period? Of course, we take care of this. Next slide, and we enter in our position statement, and these are, of course, the general comment. I guess that there will be a lot of discussion, because it's easy to say that we need to postpone the elective indication with the low risk of GI cancer, but what are these indications? Is a fit positive indication with lower or enough risk? But definitely we must pay tribute to all the governing board, because they identified next the procedure that must be done. I guess that all of us would agree that if something is emergent, it is life-threatening, it must be done, okay? If something is urgent and it is life-threatening, it must be done. If it is not life-threatening, we need to evaluate case by case. And this is the list: all of the bleeding, foreign body, cholangitis, or obstructive jaundice. Next slide. As I said, from the Chinese experience, this is a disease that requires organization. So we need to identify a leader. In each endoscopy unit, you must identify a leader. The leader is responsible of getting all of the protectors that you need. But this leader must provide training, because a lot of people have the mask and then they don't know how to put around the nose in order to close all this space. If you don't learn this, all of the money that you can spend in FFP2 or FFP3 are waste money. And this leader must know what to do if there is a positive cases, because you need to isolate. You need to contact the health authority for the testing of this person. And the second point is on a different approach. There is not the future, ladies and gentlemen, it is the present. This is telemedicine. All our kids at home, they study on some app, and we need to use not only audio, but also video to contact our patients. But of course, there will be legal, economic, financial issues in the adoption of telemedicine. But COVID is not going to leave us shortly, and I guess that all the national society that are contacted with us should look in their own specific country how to implement telemedicine in the next future of endoscopy. Next. So the engine of this position statement was the risk stratification, and I guess that when Ian started to work on it, it was quite simple. Now it's a bit more complicated, Ian. Okay, so we are clinicians, so we should be able to identify the symptoms of COVID-19: fever, cough, shortness of breath account for the vast majority of cases. Of course, we can talk about diarrhea, about fatigue, but the more you increase the sensitivity, take care, the more you decrease the specificity. But then we need to have some epidemiology insights. So if any person has been in contact with any person with these symptoms or with any COVID-19 positive, it should be considered high risk. But the last bullet is very controversial. What is today a high risk area? When Ian started to write this position statement, there were some very well identified, very red area in northern Italy, then in Spain. Now virtually all Europe has been locked down. So all Europe is a high risk area. But look at the data. For instance, in Italy today, in Lombardia, there were 1,500 new cases. Today, in my region, only 50. So is 1,500 the same as 50? Probably no. So I feel that with some wise approach, we can re-stratify the high risk area in high risk area and a very high risk area. And of course, apply triage, not only to yourself, not only to your patient, but also to yourself. And my advice is to measure the temperature, both to ourselves and our patient, but we'll get back on this in the discussion. We are very close to the end. Next slide. So this is the multi-dimensional algorithm that our governing board proposed. First, you stratify the risk of GI disease. If it is urgent, it is essential. If it is not urgent and it is elective, you stratify for the COVID-19 death risk. Two factors, ladies and gentlemen: age over 60 and comorbidity, and especially respiratory cancer. If the COVID risk is low enough, you proceed to endoscopy. Next, Claire. And here you re-stratify according to the possibility that there is a COVID-19 infection, and then you decide how to protect yourself with the rational use of resources. But I leave this to Ulrike, as she will get into the details. Next slide. This is again about infrastructure. We need a completely isolation of COVID-19 cases. If not, our diagnosis is useless. You don't want to expose your negative patient to COVID positive patients. Next slide. And of course, if you need to do an endoscopy and you admit, as we as a society admitted, that endoscopy is aerosol generated procedure, you don't want to contaminate your environment. You want to work, if possible, in a negative pressure room. If this is in the theater outside the endoscopy department, not a problem. You bring your tower. And of course, you don't want to contaminate all the surgical devices, so you will take care. But it's better if you can to use a negative pressure room. If not, you can use a separated room. Then you need to ventilate, even for 3 hours before cleaning and disinfection, because you don't want to expose the cleaners to the risk of COVID-19. So back to you, Ian, and stay tuned, everybody, for the question and answer.
Cesare, thank you very much. So now I'd like to invite Ulrike Beilenhoff, who will speak about cleaning and disinfection and what's important during this pandemic. Uli.
Yeah, thank you very much, Ian. So when we have a look at the virus, it is an envelope virus. So therefore, it can easily be destroyed or damaged by neutral detergent. So the neutral detergent damages the lipid membrane, and we can also use our normally used disinfectants, which have virucidal activities, and they also destroy the virus. So when we speak about cleaning and disinfection, we definitely can use our commonly used products. And if we have a look at the endoscope reprocessing, then it means that we do not really have to change anything. We have to follow our standardized, validated reprocessing cycle, which is in place. So most important, again, is the thorough bedside cleaning, and you suck and flush all the channels with at least 250 milliliters. And then the close transport of the contaminated equipment, of the contaminated endoscope from the procedure room to the reprocessing area is most important, that you do it quickly and that you really clearly mark the container or the box as contaminated equipment as usual. Then when you arrive the reprocessing area, then the cleaning should be done immediately. And that means even if we have this highly contaminated endoscope with COVID-19, we of course do all the manual cleaning steps but we should take care that we really do it under the water surface so that we avoid any splashes and contamination of the surrounding surfaces. The automated reprocessing in the washer disinfector is then another quality issue, that we really avoid any manual steps, so that we really have a high quality of cleaning and disinfection in the closed endoscope washer disinfector. So we should clearly avoid any manual final disinfection of the endoscope. So we should really focus on the automated systems. When we clean the endoscope, all the cleaning devices should be single use. For instance, the brushes and gloves we use. And the next step, when we put the endoscope in the washer disinfector and everything is then closed, we should definitely decontaminate the surrounding surfaces in the reprocessing area, so that we should avoid that we should destroy any contamination on the surfaces. It is most important, especially after cleaning such high contaminated endoscopes. Social distance and hygiene is highly announced in daily routine in general public, and this social distance and hygiene should also be lived in our clinical daily practice. So whenever possible, we should use this distance between each person, 1.5 meter, 2 meters, when we stand together and discuss anything. And even when we have coffee breaks or lunch breaks, if possible, we should accept this social distance. Because it showed that even during lunchtime, there were also contaminations when you look through the patient's history. The team organization is very important in order to group the staff. In some hospitals, they made 2 groups of staff, and they grouped the nurses and doctors as in one group, and another shift work on other times and other rooms. So you can arrange it however you want, but you should separate a little bit your staff and make small groups. So if you then have an infection among the staff and you have to go into quarantine, then not the whole staff has to go. And we can discuss that later. How many people should be in the endoscopy room? Cesare already mentioned training is difficult at the moment, so we should really limit the number of staff available in the endoscopy room. And from my understanding, it should be the endoscopist, the assisting nurse, and the sedating nurse. So we need, from safety point of view, we need 3 people in the room. But all other staff should wait outside, and so training is really difficult in these days. When we speak about social distance and hygiene, we should also be aware that we should not share everything at these times. So the mobile phone, the pens, even the computer and the computer mouse, and also medical equipment like a stethoscope or whatever, should be used by one person. And if we change even working places, computer places, we have to decontaminate the place between the users. So one option is when in a lot of departments, they reduced the endoscopy program, as Cesare said, and a lot of procedures are cancelled now. And if you have empty or not used endoscopy rooms, you can also use these rooms as workplaces, for instance, like offices, so you have one dedicated person per computer workstation, for instance. Correct hand hygiene is, from my point of view, one of the most important issues in this outbreak. The 5 moments of hand hygiene, we all are aware of that, but we also have to live this. And if you see the picture on the right, the person who has a watch on the side and the nail polish and jewelry, that's a way we should not work in our hospitals nowadays. So that are simple things, but we have to think about that. Limited furniture, and we have to limit furniture and equipment in our endoscopy room, so we empty the rooms as much as possible. We do not open all the cupboards. We prepare the procedure and only take off the equipment we really use for this patient. And finally, between the patients, we definitely have to decontaminate the surfaces. The most important point also to protect ourselves is not to touch our faces, or when we have the mask on, to correct the mask with the hands, or I also saw it with gloved hands. So don't touch your face, don't touch your mask when you have it on. Don't do it like the person here on the picture below, who is correcting the mask with gloved hands. We automatically touch our face at around 20 times in 1 hour, and we don't realize it. But try to watch yourself and control yourself, that you really do not touch your face and your mask when you work. So, and if you have your glasses here, it might be helpful before you put on your mask that you use any device to fix the glasses, so you don't have to correct it during daily routine. Elastic band on the back, or even some plastic things here behind the eye might be helpful. There are also things where you can fix the glasses on the nose. So that are very simple aids that can help you to avoid to touch your face. So social distance and hygiene are most important in these days. We have to use also the personal protective equipment in a proper way. And that means we have to put it on correctly and remove it correctly. And therefore, we really have to train our staff in theory and practice. We should establish training lessons, even if we have now not enough time. But if we get new stuff, we have, and hospitals ask to get more stuff, we have to train them how to put on and take off the personal protective equipment. Helpful tools can be e-learning, what staff can watch at home, but also in hospitals. A lot of hospitals have intranets where you can put on SOPs and also pictures, posters, videos. Very helpful are checklists and posters you can put on the wall in your endoscopy rooms as a visual checklist, that you really take all the different steps, and it reminds you. And we have a number of helpful aids now on the ESGENA website, and you see the address here below. You will find their checklists and posters. You will find their videos and a number of helpful literature that show you a lot about personal protective equipment. Within your endoscopy department, you have to support each other. You watch each other while putting on and off especially while you remove your contaminated personal protective equipment. So don't be afraid and don't be too shy to correct the other person and say, hey, take a minute, you contaminated yourself. So help each other, and also audit your personal, your staff that they use the personal protective equipment in the proper way. So now we can go on. We, in the ESGENA statement, ESG and ESGENA statement, we have two different risk levels. So the low risk patients and the high risk patients. And it doesn't differ so much. We all have our gowns, and that should be long sleeved and water resistant. We have our protective eyewear. Usually it should be goggles and really a face shield. I'm really a fan of these face shields because then it is a physical protection against splashes and so on. And we should also wear disposable hairnets. We wear with low risk patient normal gloves and the surgical mask. And what Cesare already said, when we wear a mask, you protect the other. So if we wear a surgical mask, we protect the patient because we can also be a carrier, and we have to protect our patients. But it is also shown that this simple surgical mask can also be a barrier. And if you wear the surgical mask and then the face shield above, you have a good protection. With high-risk procedures and high-risk patients and confirmed infected patients, then you choose the FFP2 and FFP3 mask, so a respirator, which has a close contact to your face, and you should also wear 2 pairs of gloves in order to have a better protection. So there were a lot of discussions around in the press, and you all experience it. Personal protective equipment is very short. There is a big shortage about it, and there is a big business going around. And hospitals try to organize personal protective equipment all over Europe, and we hope to get more. But therefore, you should really make clear instructions which masks should be worn on which kind of patients, which kind of procedures, so that we do not waste our resources, that we really use the right masks for the right patients. And also, who should wear masks? Should all the patients get a mask when they enter the endoscopy unit, or even when they enter the hospital? This has to be discussed within the hospital, and clear instructions are very useful. With a prolonged use of masks and FFP2/3 masks, it can be an option, but in endoscopy it is quite difficult because we have a high risk of contamination, especially with the upper GI endoscopy. So a prolonged use can be difficult because then the mask is contaminated. That should be discussed. The mask is a protection of yourself, and if you use the simple, as I said, if you use a simple surgical mask, it's very helpful to have this shield above, that you have a physical protection. And also the eyes need to be protected. So Google, not your own glasses, but Google's above that, or also a shield is an additional protection. If you use reusable gloves and reusable goggles and shields, then you should not forget to decontaminate them in between the patients. The communication is a key issue in staff protection. So as Cesare said, the triage is not only a task for the patient, but also for the staff. And we should communicate it honestly and say, hey, I don't feel well, I stay at home, because then we protect our own staff and our patient. So we have to have an honest and transparent communication. Otherwise, we have a chain of infections, and we want to stop that. So all the recommendations change very fast in these days. So you have to update when new recommendations come from your official bodies. You have to update your SOPs constantly. So that is a lot of work, especially for head nurses and infection control responsible people. Another key issue concerning shortage of material is that you have to check the availability of material and stuff every morning, every day. And you have to communicate it clearly if there is any shortage, and then you have to react. And also if there are any additional problems, like that an endoscopist or nurse got ill, and what should happen then and then. So communication is a key issue. And again, all these things, we have to protect our patient, but also staff protection has priority. Otherwise, we cannot care for the next patient. Thank you very much. So are there any questions? Ian.
Yeah, Uli, thank you very much. We're going to get to some questions, but I want to keep you for a second, because there was a question that came in And I want to remind everybody, there is a function for questions. Please send your questions and we can try and get them up to our panelists. But somebody actually specifically wrote in about what is the necessary personal protective equipment for the person who's actually cleaning the scopes afterwards. And is a surgical mask enough, or is it better to use an FFP2, the person who's cleaning the scopes afterward?
So the question is, what does the person have above the mask? So if you have the surgical mask and then the shield above it, and you can also have closed shields, then I think that is enough. But if you don't have these shields, then you should have a closed mask at a minimum. The FFP2 masks are not available everywhere, and the number is quite limited. So we have to be careful when to choose these. So if you combine the masks with the shield and with a closed shield, that might be enough. But if you don't have these shields, you definitely have to use the FFP2 mask for endoscope reprocessing as well.
Okay, all right, thanks. Let's open this up actually to the panel. So let me ask you, Maria and Alanna. I'll start with Maria. How are you currently prioritizing the indications for endoscopy?
Well, I think this is a very important question, especially in those countries where maybe the prevalence of the disease is still not very high, because first one tends to think that well, maybe a big polyp is important to be performed. But I think that we really need to think in another way around. We really need to think that this is only happening once in our life, I hope, not many more times. And I can tell you that once the outbreak is in your hospital or in your on your city, things change very quick, and then all resources are really needed for COVID, and it's then too late. So it's very important that, as Cesare has explained very well, and it is also reflected in the position statement, that all the elective procedures should be postponed. You really need to think about it. If anything that can be postponed 3 months, it is better to postpone it and wait until this goes, because whenever there is one patient that is ill, then it will be very easy that many people in the unit will get ill, and then that's a big problem once the outbreak is here. Once the outbreak is here and you have a lot of patients coming to the hospital with COVID, things become very easy to prioritize, because then everything is clear that you only can do the really urgent endoscopies, only the upper GI and rectal bleeding with hemodynamic instability, or the anemias with instability, or those ones with a foreign body, or a cholangitis, or obstructive jaundice, because then the resources are very small and you just need to do the emergency ones. But I think that before this happens, just this 15 days before, it is very important to postpone all the elective non-urgent endoscopies and consider them very well, because that's our lesson. I think that if you don't do it at that moment, then it is too late, and you really think that you should have done it before.
Okay, thanks, Maria. Alanna, I assume you're doing the same thing in Augsburg?
Yes, we are. Basically, just like Maria said, there are various phases in the prioritizing of indications. And the first phase is when you still have time to postpone elective procedures. And the second phase is the emergency phase, where Italy and Spain and some areas in Germany are in now, where it becomes very easy to prioritize, just like Maria said. You then go only for emergency procedures or very urgent procedures. The more important question, or an interesting question would be, how do we then unwind all this at the end of the COVID situation? How do we go about re-unwinding the knot we are in now in the post-COVID era? That will be a very interesting phase of the development.
Yeah,
Thanks, Alanna. Yeah, Cesare, I want to ask you something about personal protective equipment. what are the differences? I want you just to very quickly review from the position statement, the differences in PPE for a patient who is suspected versus the patient who is known to have COVID-19 infection who is undergoing endoscopy. What's the difference? What do they need to know?
So usually in the position statement, we recommend that any patient who is at high risk of COVID-19 should be treated as a COVID-19 patient. And this means with a respirator that block also the aerosol. But it is also true that something is a patient with a high risk, something is a patient with a known COVID-19 infection. In this case, I guess that all of us would agree that if an FFP3 with 98% protection from the small particle is available, this should be used. If not, at least the FFP2 should be used in these cases. I must admit that to scope a COVID-19 patient with a surgical mask is somewhat suboptimal or out from our standard. So for infected, FFP3, for high risk, possibly FFP3 or FFP2, for low risk, surgical mask.
Maria and Alanna, do you agree with that?
Maria?
We should use FP2 at least.
Yes, I agree.
We should use FP2 at least.
Uli?
But that is what a lot of hospitals already established, as I know from communication with other colleagues from other countries, that they now said, okay, the difference between low risk and high risk is difficult. We do FFP2 for all endoscopy procedures, and then we are on the safe side. And we can use surgical masks in our areas, but not in endoscopy. So if FFP2 masks are available, then they definitely use FFP2 masks for all endoscopy procedures.
Well, right now in our center, what we are doing is we use surgical masks for the basic endoscopy procedures where we don't have any suspicion whatsoever that the patient has a COVID infection, in order to save the FFP2 and FFP3 masks. Yes.
Let me bring up another point, and I think this should be clear, is that we're really talking about any endoscopic procedure. Doesn't matter if it's an upper endoscopy, ERCP, EUS, or colonoscopy. Do you agree with that, Alanna?
Yes, I agree perfectly well. We know that endoscopic procedures, at least we agree that endoscopic procedures produce aerosol. Whether we are doing an upper GI endoscopy or a lower GI endoscopy. There are studies also that show that an endoscopic or a person present in the endoscopy room standing 3 to 5 meters behind the patient, behind the endoscopic procedure, still receives tiny droplets, can still receive tiny droplets from the aerosols being generated during the endoscopy. And another point is, remember that the SARS-CoV-2 virus has an affinity also for the intestinal tract, for the gastrointestinal tract. There are the ACE2 receptors in the gastrointestinal tract, and this has been shown in various studies. Also remember that the SARS-CoV-2 virus has also been shown in the stool of infected patients. So there is a risk for aerosol and contamination, both from upper and lower GI procedures.
I think that's an important point. In fact, there were several questions from the audience that were specifically asking that, looking at what is the risk to the endoscopy staff, upper versus lower. And I think we really need to approach these patients that there is no difference, and that whether we're doing upper or lower, it's the same. We need to take the adequate precautions. Go ahead, Cesare.
So my only point is that beyond our protection, we can also put a mask to the patient. So during colonoscopy, both the patient and the physician have the mask. when we do an upper endoscopy, of course, the patient has the mask until immediately before and immediately after. But during the procedure, there is a moment where you have the mask, but the patient doesn't have the mask. Does this mean that upper endoscopy is at a higher risk than colonoscopy? I fully agree with Alanna, and this is our position in the position statement, but some research in the future could tell us if a selective use of FFP2 should be recommended for upper endoscopy. I want to be honest with you, Ian. In Italian hospital at this stage, we don't have enough FFP2 to do basic upper GI endoscopy. So we need to rely on our surgical mask. But having said that, I know that now I will irritate a bit Alanna. If you look at all randomized trial, there is not so much clear evidence of FFP2/3 over surgical mask, and this has been attributed to the fact that in order to use respirator, you need to have a much better training than with a loose surgical mask. And consider that the self-perception of the ability to use the equipment does not correspond to the truth. For this reason, Ulrike, training and retraining with practical lesson of the staff is essential in order not to waste the FFP2/3 patrimony.
I think that's an important point. Uli, do you want to comment on that?
Yeah. just to highlight that if you really wear the surgical masks, then you really need to have these shields before the face. If you just have the goggles, from my point of view, that is not enough. So if you really use the surgical mask, the staff should be you should use these shields. I think that is most important. And there are also studies who show that there are a lot of contamination on these shields, and that highlights that they really protect the staff.
I think that's a good point. Maria, do you want to add something to that?
Yeah, I totally agree with Ulrike. I think that in this moment of the pandemic, that I hope that it will go in 1 month probably, and it will be over. So it's 1 month in our life. I think that in this month, it is especially important to be careful. And if there is shortage of FP2 masks, we have to ask for more or find other ways. And I don't think it's the moment to not to do it. I don't see the reason.
Is anybody re-sterilizing masks at your institutions?
We are.
Maria, you are. You are.
Yeah, what we do is to put the FFP2 or 3, and then we change the surgical mask. We put the surgical mask over, and we change because the risk that the mask can be contaminated, as Rick was saying. So we protect the mask with the second mask.
That's exactly right. That's what we do as well. But remember that that procedure needs the staff to be especially careful when removing the personal protective equipment, because you don't want to contaminate your FFP2 mask after removal, because you want to reuse it again. So you have to be extra careful.
Let me ask. Let me.
Just one addition. What a lot of hospitals now do in Germany is that they contact also other industry and say okay, automobile industry, chemical industry, people who work with wood or with colors, whatever. Any companies around the hospitals are contacted now and ask, do you have surgical, do you have masks, FFP2 masks and so on, which you can give us? And there is also other industry who can give these masks to hospitals in these days.
That's a good point. I want to shift a little bit. I want to ask some specific clinical issues. So Maria, what are the procedures? What are the endoscopic procedures that you think at this point are absolutely necessary, we need to be doing?
Apart from the emergency ones that have been already, apart from the emergency ones that have already, there are the emergency ones that have already been.
So say that again. What are the emergency ones in your opinion?
Okay, so all the upper and lower GI bleeding that have hemodynamic instability, the anemia with hemodynamic instability as well, the foreign body in the esophagus, the cholangitis, the obstructive jaundice without cholangitis, and then there are several others that will be evaluated case by case, obviously, depending on each situation and each hospital and the patient.
What about foreign bodies, esophageal foreign bodies, sharp foreign bodies that are in the stomach, Alanna? Are you doing those cases?
Oh, yes, definitely, yes. That's a clear emergency case, and we're doing such cases, yes.
Okay.
Right now, in our center in Augsburg, we have a large caseload of COVID patients, yes, but we are still in a we're not yet in that severe emergency situation, and our prioritization will probably be different from what Maria and Cesare have been doing. So it's very important to stress that these things are dynamic and vary also from region to region. And from time to time, it can change within 1 or 2 weeks.
Not 1 or 2 days.
Yeah, even 1 or 2 days. Cesare, let me ask you a question in terms of malignancy risk. Are you doing cases right now for those cases where somebody's had a CT and they think that there's a mass lesion either in the upper GI tract, the lower GI tract, pancreas? Are you doing those cases right now, such as an EUS with FNB because of a suspected pancreatic head mass, things like that? Tell me about that.
Okay, so first I want to tell what every day I need to deal with. I'm also curious about what Maria is doing. In Europe, several countries have an organized screening program, and all the people are invited to do the FIT. If you are FIT positive, you have a 30% chances to have advanced neoplasia, 5 to 10% chances to have a cancer. Okay, the health system in Italy push us to continue to do colonoscopy in FIT positive. So I feel we can use this as benchmark. Here in Italy, but I guess in Europe, they stopped to do FIT. But for those who underwent FIT, you need to do colonoscopy. So if you need to do colonoscopy for FIT positive, Ian, you're going to do colonoscopy only for a radiological suspicion of a mass, unless as in North Italy, all the ICU would prevent a surgery at that time. So what's the advantage of finding a cancer?
Maria, what are your thoughts about this?
Well, again, it depends very much on the moment you are living. But of course, there is a very nice Italian paper that will be very soon published in Endoscopy that shows that the incidence of cancer in a FIT positive patients when you delay the colonoscopy doesn't raise until 9 months. I mean, if you do the FIT positive and you wait 9 months to perform the colonoscopy, nothing will happen with that patient. The only thing that will happen is that he will be waiting at home, but no more cancers will appear in terms of the advanced adenomas. So, so there is, I think that we can wait. We are just talking about some weeks. And on the other side, I don't know, maybe it's because what we are living in my city, and I hope that it doesn't happen to other places apart from Lombardia, Madrid, and Barcelona. But maybe it will happen, because 2 weeks ago, I can tell you that we were having this same discussion and many people were saying different things. And right now, there is no discussion anymore because we are not doing any surgery, any elective surgery in the hospital. We are not doing any CT to anybody apart from COVID patients. We are only visiting COVID patients. So this is something that I hope it doesn't happen to the others, but everybody must know that once there are a few cases in your city, the possibility that other people that are healthy apparently and are just coughing around and spreading the virus is real. It's not just an entelechia, it's something real. And once the outbreak starts, then there was no sense in doing those colonoscopies. So I really think that as endoscopies, we need to stress that only for 1 month maybe, but this is the reality.
Alanna, do you have anything to add?
Well, just briefly, in our center, just like what Maria said, we are still maybe 1 or 2 weeks in front of what Maria just described. We are basically still doing all procedures that have any suspicion of cancer.
Yeah, we're doing that too, actually. If there's a suspicion of cancer, we are doing that because our surgeons will actually, because we're not in the situation that you are in Italy and in Spain, if we were to find something, our surgeons would take those patients to surgery and their surgery wouldn't be delayed. So we're actually impacting the medical decision making. We are doing those cases right now. Uli, there was a question regarding disinfecting the rooms, either of patients who are low risk or high risk, and are you doing anything any different?
No, no, we have the detergents and disinfectants you use are usually have virucidal activity. Also for the surface decontamination. So we use our normal products for hand hygiene, for instrument decontamination, also for surface decontamination.
So what we do in our practice is that if you scope a COVID-19 or high risk, you clean and disinfect the room immediately before the next case. That will probably after some time. If you scope only low risk, you do a complete cleaning and disinfection at the end of the session, as it was in the pre-COVID-19 era. So this is the difference in protocol we have for rooms who scope high-risk patients, for room who scope low-risk patients in cleaning the room.
But you also, between normal patients, the low-risk patient or normal patients, you decontaminate the patient near surfaces. So you do a decontamination in between. Yeah. But not a full room decontamination.
Yeah.
Yeah.
Are you, to the three gastroenterologists here, are you scoping COVID-19 positive, known positive patients in your current endoscopy rooms if there's no negative pressure type of a room? Or are you moving them to a different, are you moving them to a room that has negative pressure? I'll start with Cesare.
So if so since we have a different hospital, if I have the negative pressure, that is the operative theater, I prefer. If I am in a facility with no negative pressure, I scope, but then that room becomes isolated, probably until the end of the session.
Maria?
Unfortunately, we don't have the possibility of having a negative pressure right now, so we do it without, but what we try to do is really, as Cesare was saying, to do everything in one room with the very few people inside the room, and then try to do all the things that Ulrike has explained very well.
Alanna, what are you doing?
So we have the possibility of scoping a negative pressure room, but it's technically very difficult to switch from negative pressure back again to normal pressure to positive pressure. It's technically difficult. That means you're designating one whole room only for the COVID patients, and that means you're but most of the procedures we've done now have been on our severely critically ill patients on the intensive care ward, and we transported our endoscopy tower to the intensive care ward and scoped the patients there. And there's no negative pressure room there.
Yeah, good point.
Yeah, so that's a good point. If those types of patients, if it's better to do them bedside than to bring them to the endoscopy suite.
Exactly.
Okay. The other, any of you had any experience, because they've discussed this here in Israel, about using these sort of big HEPA filter machines to put in the endoscopy unit to try and filter the air. Any experience have you had with that or heard anything about that?
No.
Okay.
No experience.
Okay. All right. Okay.
I just saw a video, Chinese video.
Yeah.
There is a Chinese video.
About HEPA filters?
Yeah.
Okay,
Yeah.
I've not seen that. We're coming towards the end. We're a couple minutes over, but I wanted to ask two more things. Alanna, do you want to add anything about fecal oral transmission? We talked about the risk of colonoscopy, about specifically doing stool testing. Can you give us a comment about that?
Yes, a very, very important point. Just briefly, you know that about 20% of patients that have a negative pharyngeal PCR still have a positive stool PCR. So that's an additional possibility of testing a high level of suspicion with a negative pharyngeal PCR. If you can't get sputum, you can test stool as well. So that's the first point, but it doesn't add up necessarily to the fact that stool, a positive stool leads to fecal oral transmission, because we don't know for sure whether those viral particles that we're discovering in the stool are really infectious. There have been some studies on cell culture. Cell culture has been able to be infected with positive stool, but that still doesn't really prove conclusively that fecal oral transmission has taken place. It's possible, yes.
Okay. Okay. Thank you. Cesare, go ahead.
So I fully agree with Alanna that at this stage there is no firm evidence that orofecal transmission occurs. But this had immediate implication, because when we isolate the patient, we don't only need to isolate in the room, but also in the toilet. So this had anyway a practical implication, and to show if this is true or untrue would be useful for the separation of the patient.
Thanks, Cesare. Lastly, any of your hospitals testing the medical staff just routinely within the endoscopy departments? Cesare, I'll start with you.
So not in my center, but in Italy, there are two centers who test all the inpatients, so not the staff, all the inpatient having endoscopy with suspicion of COVID. But Ian, let me say that for me, testing is the game changer. Do you remember when we were young, there was the test for Hep B or Hep C? So we cannot exclude that in the future, there will be a test for any patient coming to endoscopy, or anyway, for some patients coming to endoscopy as much as for the staff. So I guess this may be the future.
Maria, is your staff being routinely tested?
We just started this week to have these written testings, and there are a lot of surprises, as you can imagine, many people who were asymptomatic that are positive. That's why it's so important. I think, as Cesare says, testing is the game changer. And of course, when I was saying about stopping elective procedures, if you have the possibility of testing, then everything changes, because then you are not blinded anymore, and it's much easier to work. And so here is the clue is about testing, and I think it's very important.
Alanna?
So we are not testing staff, asymptomatic staff routinely, not because it doesn't make sense or it wouldn't make sense, but because the availability of tests is the problem. So we need to save tests for symptomatic patients, or symptomatic staff. Exactly.
Uli, is that the same where you're at in Ulm?
Yeah, that is what I also heard, that people test stuff when they have the idea that they are contaminated, but not routinely.
Okay, all right. Listen, we're a few minutes over, and I think we're going to draw this, what I think was a very successful webinar, to a close. For the audience to know, we had almost 1,000 people who signed up for this webinar, which is amazing. And we had 500. The maximum was only 500. We maxed out on the attendance for this webinar. I want to thank everybody who sent questions, everybody who attended. I want to thank, of course, all of my panelists. We need to thank the webinar team, Claire, Guy, and Dave Inker, who without their help, this could not be possible. And I want to thank the ESGE and for inviting all of us and the governing board. I just want to say to everybody, please take care of yourselves, take care of your families, take care of your patients, and just protect ourselves. And I hope that this was really helpful to everyone out there. If you want to view this again or have your colleagues see this, the recording will be on the ESGE website. So I invite you to look at it there, and that should be up hopefully within the next day or two. So thank you again very much. The next webinar is scheduled for May 13th. How can I improve the outcomes of my EMR, which will also be a great webinar. So thank you again to everybody, and good night, and stay safe out there. Be well. Bye-bye.
Bye-bye.